we are. I just needed to start a couple of things on my end, and we will
Thank
get
you.
started. Um, so welcome everyone for our webinar, which will discuss what's new in treatment and care for adolescents. It was organized by the Child Survival Working Group of the IATT for the prevention and treatment of HIV infection in pregnant women, mothers, and children. Um, as we know, AIDS is the second leading cause of death among HIV positive adolescents globally and the number one cause of death among this population group in Africa. And the WHO is expected to release new guidelines officially very shortly. And these guidelines also include recommendations specifically for adolescents 10 to 19 years of age. And in the recommendations there has been included recommendations concerning when to start ART and service delivery approaches. So this webinar will really provide a preview and an overview of the guidelines as well as all of the evidence and the rationale that informed and fed into the development of the guidelines. And these include clinical as well as service delivery recommendations, global standards for healthcare services for adolescents, as well as 3 pieces of work that informed the development of the guidelines. And this includes a global consultation with a network of young people living with HIV from Burundi, as well as a situational analysis of health facilities across 23 sub-Saharan African countries, and service delivery retentions to improve adolescents' linkage, retention, and adherence to ART. And as you see from the agenda, we will start with an overview, a framing of the issues, as well as an overview of the evidence. And we will have Q&A sessions in between the presentations to allow for discussion, comments, and any questions. Also, to let everyone know, we will be distributing the presentations and the recording following the webinar so you can share with your colleagues. And without further ado, I'll turn over the first overview to Dr. Martina Penizzato of WHO, who's the pediatric HIV advisor in the HIV department at WHO, and she brings extensive experience as a pediatrician and working for WHO on research on pediatric HIV, as well as clinical experience. And without further ado, I'll turn it over to her, and her colleague Alice Armstrong will be joining her in a presentation following Martina's overview. And Alice is currently a consultant with the HIV/AIDS department at WHO, where she provides technical advice on prevention, testing, treatment, and service delivery for adolescents. She has more than 10 years experience in adolescent HIV programming, and she contributed to the development of the consolidated ARV guidelines update. So over to you, Martina and Alice. Thank you so much for joining us and presenting on our webinar this morning.
Thank you very much, Jessica, and good morning and good afternoon, everyone on the line. So as Jessica mentioned, I just want to make a few remarks to really frame some of the work that you will hear during the course of this webinar. I think that, as Jessica mentioned, it's important we remember that there's about 1.2 billion adolescents estimated to be living in the world. And we know that out of those, about 2.1 million are estimated to be living with HIV. We know that there are new infections occurring, and hopefully we'll have updated number in very soon, around the mid of this year. But we also know that as we scale up pediatric programs, children will survive and will become adolescents with a number of different challenges attached to really the sequencing of treatment and use of different drugs as they age. I think it's important to remember that HIV-related deaths among adolescents are estimated to have tripled since 2000. And as Jessica mentioned, that made it the second cause of death among adolescents worldwide. I think it's important to point out, however, that the limited availability of age-disaggregated data and data from programs attached to this specific population really makes it difficult to have accurate estimates, particularly of health outcomes for this age group. And there's certainly ongoing efforts that a number of different partners are putting together to ensure that these the development of estimates is as accurate as possible. So we will probably hear something more towards the mid of this year in terms of numbers. I think that despite the lack of data that are coming from program, we do have evidence that indicates that adolescents living with HIV are underserved by current HIV services and are at high risk of loss to follow-up and poor adherence. And also present increased requirement for comprehensive care, which should include psychosocial support, sexual and reproductive health care as well. All of these obviously highlight the potential challenge that we face when we scale up treatment for all adolescents. And as you know, this is one of the key highlights of the new guidelines. And really emphasize the need for us to explore, understand, and implement evidence-based interventions that support this scale-up. And in order to capture this, the WHO ARV consolidated guidelines that were developed in 2015 and that will be released very soon in its full form, but that have been launched in ICASA in November last year, really recognize adolescents as a more discrete population and really aim to capture some of the specific needs and some of the specific elements that we've just mentioned. So that was done both on the clinical level, but also and most particularly at the operational level. So moving into the first presentation that we will have today that really aim to summarize what's new in these guidelines that you will soon have access to. I wanted to sort of emphasize help you orientate a little bit within the guidelines, and remember that there is one clinical section. There is a number of chapters that speak to the clinical component of the guidelines, but then there is a very rich part that really speaks to the operational challenges and operational elements of scaling up treatment. And so with regards to the clinical recommendations that you see in these slides and some of the key areas that were addressed in these guidelines, of course, adolescents were included in the when to start recommendations, but also fully captured within the what to use recommendation. I will particularly focus on that in my bit of the presentation. In the operational part, adolescents have a very specific session that is dedicated to them, and Alice will tell you more about the background work that informed development of that recommendation and some of the other elements that were included in that to support implementation. So focusing on the clinical aspects, I just want to remember everyone the treat all recommendation that everyone is aware of that was disseminated through an interim guidance that was issued in September. As you remember, as part of that, all adolescents are recommended to be started on ART at any CD4, but we did capture a prioritization element that would ensure that those that present with symptoms or have low CD4 would have priority when starting treatment. I want to touch on this again because I think it's important for us to fully understand why this recommendation was a conditional recommendation, and really to remember to everyone that this is just a result of the lack of direct evidence as compared to the one available in adults, and that the need really to extrapolate data from adults and pediatric studies. I think that the evidence in adults is pretty clear. The evidence that we have for children is less direct, so to speak, but I think it does point towards the significant impact that ART has on growth, neurodevelopment, and immunological recovery, as well as in preventing pubertal delays. I think it's important to recognize, though, that all these studies do suggest that the gains that adolescents that were vertically infected might be more limited. And I think this contributes to really the concept that the balance between risks and benefits of treating early at any CD4 might be slightly different from the other populations. But it's really it's helpful for us to emphasize how important it will be to really ensure that the right services are provided to adolescents to ensure that this recommendation is scaled up properly and safely. I also wanted to remind everyone that Uganda is certainly the first country that has experienced treating all children and adolescents less than 15 years. And while these experiences obviously emphasize the programmatic advantage of such a recommendation and really the simplification that is resulting from starting everyone on ART without waiting for CD4, really promotes a quicker and a faster engagement in care of people living with HIV, and particularly of adolescents, knowing that that's such a challenging element of providing care to them. But it does emphasize how important the planning phase is, and how really providing the right support to adherence will be critical. And obviously that's particularly important for the population that we're talking about today. And so for adolescents, this would be very, very critical. So moving towards additional the other recommendations, it's important to recognize that there was certainly a focus in finding the optimal treatment for adolescents, and there's a number of technical discussions and technical meetings that happened before the guidelines that fed into the guidelines. And so the outcome of all these discussions was really to ensure that a more potent and tolerable regimen could be made available for adolescents. And that actually worked out pretty well, because at the same time, adults' recommendations were revised to include alternative regimens such as dolutegravir-based and efavirenz 400-based regimens. The first being a new class with a potent drug that potentially really deal with the challenges of adherence, and the second one being a solution that potentially minimize adverse effects and therefore emphasize and support adherence. So I think that the other positive elements of this new recommendation is that we've maintained the full alignment of treatment regimens in adolescents with adults, and that's been seen really to be a very desirable element for programs. And so we're hoping that this will continue, and it will simplify really initiating and using the best drugs for adolescents. Another note that I wanted to share is that as within these guidelines, there will also be some guidance provided to enable simplification of treatment regimens for those adolescents that had started treatment during childhood and may be in treatment regimens that are in a way less suitable to support adherence. And so some guidance will be provided in these guidelines to really move for example, towards using adults regimen with one pill once a day. That will obviously help adherence. I also, however, want to recognize that we did not have any adolescent-specific evidence, and that these recommendations that as I mentioned, are coming mostly from the adult world, are really emphasizing the lack of adolescent-specific data that these studies have, and none of the studies considered had adolescents, and we did use these data to extrapolate and really to inform the decision about the best regimen for adolescents. And one of the methodology that is fairly innovative that was used in these guidelines is the network meta-analysis, and this approach was really used to maximize the availability, to maximize the use of the data that are available currently, even if not resulting from head-to-head comparisons. And when looking into that, it was clear that integrase inhibitors, particularly dolutegravir, had better performance in some of the clinical outcome, but that efavirenz 400 was probably better compared to the standard of care in terms of particularly CD4 recovery and treatment discontinuation. And all the three options, so dolutegravir, efavirenz 600, and efavirenz 400, were considered to be comparable in terms of severe adverse effects. Moving into the way we monitor ART, there's not big news to share, but I wanted to remind everyone that certainly viral load monitoring is the recommended approach to treatment monitoring, and that continued to be the case. And we've provided more details with regards to the frequency of viral load monitoring, as you can see in the slide. But I also want to flag that these were specifically looked at for adolescents, and the group was asked whether a more frequent viral load monitoring was needed or advisable in this specific population. The group decided not to recommend any more frequent viral load monitoring and really to align these recommendations with adult population. So I think I'll just close the first part, the clinical part, by just reminding everyone that, of course, as part of this process, we have come across a huge data gap. And as we move forward, there are a number of clinical research gaps that we'd really like to be able to fill. Certainly, the need to assess the impact of ART on retention, adherence, and the link to selection of HIV drug resistance will be critical in this population. We're also keen to look into the long-term efficacy and safety of these alternative regimens that have been added to the options for treating adolescents. And then again, thinking about the long-term toxicity of drugs like tenofovir, particularly in the context of malnutrition and delays in growth and development that we know are particularly present in those that are vertically infected. We certainly want to move forward the treatment optimization agenda for adolescents, and we're really hoping that the long-acting formulations will be investigated very soon in this age group, because these will be a particular suitable, particular advisable for supporting adherence. And lastly, I think that it's very clear that AIDS disaggregation of existing cohort and surveillance data would be very critical to really help us understanding more some of these specific issues and needs that affect the clinical outcomes of this population. So with that, I will let Alice to continue with the operational part of our section.
Great. All right. So from our emerging outcome data and our growing experience that we have in providing treatment care and support services for adolescents, it's really evident that we need service delivery approaches to be able to engage them in care and support them to ensure improved health outcomes. So addressing how we provide these services to adolescents is not really exclusive to those living with HIV or new to adolescent health. There have been a number of previous efforts that have been done at WHO, including within the HIV department. And here I'm just outlining some of the service delivery recommendations that were part of the HIV testing counseling guidance back in 2003, where they focus on community-based organizations and the training of providers. And as Martina says, as we moved towards scaling up treatment, there is really a recognition that we require further efforts to address the specific ART and care-related needs for our adolescents living with HIV. So in response to this, in the lead-up to the guideline meetings, we held a scoping consultation with many experts from around the world to identify, of the many areas that we face, what do we really need to focus on for the ART update, and what are the key adolescent PICO questions, and what are some key areas within the guidance that we need to consider adolescents as a subpopulation. So this also involved key background work that informed the meeting and the decisions that were made there and were later used to further develop the guidelines. And you'll hear a bit more about those later in the webinar today. So through this process of the background data and the consultation, it really led us to highlight the need to investigate the effectiveness of adolescent-friendly services within HIV services. As a result, the Guideline Development Group made a strong recommendation after reviewing the evidence, and this recommendation is for adolescent-friendly health service approaches should be implemented in HIV services to ensure engagement and improve outcomes. So I think we continue to often think about adolescents as older children or younger adults, and we often impose how we view children and adults onto them. But we all know that adolescence is a time of rapid development and change, and it's often characterized by ongoing brain development. This really impacts on their abilities to make decisions, their risk perception and rewards. It's also a time where they're forming their sexual identity, a time of experimenting with new ways of socializing and also pleasure seeking. It is the changes during this time that are often exacerbated. The changes during this time often exacerbate these barriers that adolescents face in accessing and staying in services, and these really have a profound impact on the way that they engage with care, and they require a different response. So if we think about their reduced access, adolescents have inadequate health literacy. They often suffer from limited resources. This is not just money, there's also support, even documentation that they may need to be in different services. They have limited availability to navigate the health system. There's often a demand for parental consent, and this can't be achieved for many adolescents. Their health-seeking behavior is also very different. They're not illness-orientated. They often don't have the information they need or know where to get the services that they need. Particularly for those who are vulnerable and those who are from key populations, there is the additional stigma and discrimination that often further perpetuates their exclusion, and it hinders their access to care and support services. Their engagement in care is also impacted on by the poor qualities of services that they attend. Adolescents often perceive the health services as unacceptable, especially in regards to the lack of confidentiality and health provider attitudes. Services are not always organized to accommodate the needs and routines of adolescents. They're in inconvenient places. The times are all wrong, and they have very inflexible appointment structures. The environments are often unwelcoming, and the services are orientated towards adults and small children, and often adolescents are lost, particularly in tertiary referral centers and services where and places where services are separate. So we get asked this a lot. What are adolescent-friendly service approaches? What do we mean by adolescent-friendly approaches? And the WHO Quality of Care Framework provides a very useful working definition of what adolescent-friendly services are. These are services that are acceptable, accessible, equitable, appropriate, and effective. They service policies and procedures that don't restrict the provision of treatment and equal care to adolescents. There are services that ensure that they are free, affordable, and are convenient for adolescents. There are services where adolescents are well informed about what interventions they can access, where they're available from, and how they can get them. There are services where adolescents feel or know their confidentiality can be guaranteed and their privacy is ensured. There are services where providers are non-judgmental and considerate, and there are services where they are provided with the appropriate package of interventions in the right way and ensuring that those interventions are the most effective ones. So the WHO has a number of documents. These are from 2012, and these documents really clearly define what adolescent-friendly health service approaches are, and they also provide the guidance on what needs to be done to provide adolescent-friendly services. Since then, WHO has moved towards further developing concepts around adolescent-friendly services, and at the end of last year, there was an updated, there was a global standards were released, and these provide implementation guidelines on guidance on how adolescent-friendly services can be achieved. And Valentina Beltag is here today, and she has worked on these, and she will be providing more information in a little bit regarding these. So how did we come to our decision on making the recommendation of adolescent-friendly health services? So after the scoping meeting, as I discussed with you, we commissioned a systematic review by Lisa Butler and her colleagues, and this systematic review was to look at the effectiveness of adolescent-friendly services. And from our background work, particularly the service delivery review by Peter McPherson, we decided that we needed to have really an expanded, broad search. And we wanted to look at all adolescent health services and then also up to the age of 24. So there were 1,706 studies that were identified from the search and through 6 electronic databases that looked back at a 10-year period. A number of them, the number of the studies were excluded because they were just interventions targeted at adolescents, not interventions that fell underneath either the characteristics or the standards of adolescent-friendly services. This led us to having 19 studies included, 10 of which were RCTs, 9 were observational studies. And when we went to do the analysis, first we looked at the impact, the effectiveness on all adolescents, and then we did a sub-analysis where we looked at adolescents living with HIV, and there were 4 studies particularly that addressed this, and these were analyzed separately. After that, we looked at the quality of the evidence, and that was then presented to the guideline group. So what were the key findings? So we found that adolescent-friendly health services versus standard of care showed small but yet significant improvements. So if we first look at the analysis of all adolescents, the improvements were on health outcomes, healthcare utilization, uptake, knowledge, attitude, sexual risk reduction behavior, self-efficacy, and service acceptability. When we look closer at adolescents living with HIV, there was impact on viral load reduction in the short term and ART adherence in the long term. However, no difference was found to healthy lifestyles or quality of life outcomes. This will soon be published by Lisa Butler and her colleagues, and this will focus broadly on all adolescents, but also include aspects for adolescents living with HIV. So all in all, good news leading us to the recommendation that we made. So as part of the WHO guidelines development process, where we look at the evidence and we move it towards decision making, we look at many different aspects that are often beyond just the effectiveness that we find from big systematic reviews. And one of the areas that is considered is feasibility. And for adolescent-friendly services, this is one area that is of particular importance. So the published evidence on feasibility, specifically for adolescent-friendly services within the context of HIV services, there was no evidence available, published evidence available. So we looked at this from both a facility and a country program perspective. From the facility perspective, they highlighted that although there were financial costs to implement adolescent-friendly service approaches at the facility were low, there were considerations that were needed, particularly in regards to human resources, training, the involvement of stakeholders, in particular adolescents, and the time that it took to plan and restructure the services that they had. A country program perspective, particularly for scale-up, the countries highlighted that there needed to be a coordinated response, that there was importance that they aligned with other adolescent policies and guidelines that already existed within countries, and they highlighted the need to really link community interventions that were being provided with the facility. And then finally, there was a real emphasis from the country program perspective on what national and monitoring evaluation frameworks were available, and to ensure that they were age disaggregated, and that there were clear indicators for adolescents. We do acknowledge that we need further understanding in this area, and there is a need for implementation science and operational research. So it's a bit of a plea to all of you out there to be thinking about this when you are adopting this recommendation, or already have services that are providing adolescent-friendly service approaches, and ways that you can support this agenda of understanding more both the feasibility and the scale-up. So really just very quickly, because I know time's running out, I just wanted to highlight that there are a number of other service delivery recommendations where we have included considerations for subpopulations, and adolescents were included within this. So I've just highlighted there some of the recommendations, and just so you know that within the guidance we will have outlined adolescent considerations. So these are just some of the ones that are outlined here, so look out for those within other service delivery recommendations. So there are a number of resources already available. As I said at the beginning, that there has been a lot of work that has been done in this area, and these are available to help to support the implementation of this adolescent service delivery recommendation and the other considerations. And we'll have Valentina Baltag now come to discuss with us around the new global quality standards. And just to say, we have a number of activities and bits of work to follow up on the guidance that we have done, which has included adapting the quality standards for HIV services, looking at a prioritized research agenda. Also, we've been working with the Global Fund to make sure that there are strategic investments for adolescents, that these aspects are included within Global Fund information notes, and continue to provide tools and support for country-level implementation. And finally, Valentina could also maybe do a quick update that there is a global framework for accelerated action for adolescent health, and there are opportunities that you can be all involved in inputting in that, and that's beyond HIV, that's across WHO in many areas. So that's it from me, and I'll now hand over to Valentina. Oh yes, thank you to lots of people. Yes. So Jessica, are you able to upload the next slides?
Yes, it takes a
Great.
few seconds, so
Then I'll say my proper acknowledgements to all the adolescents and service providers that were involved in the consultations, to the different networks and groups that were involved, Y+, PATA, and to all our fantastic review teams.
Okay, great. Thank you so much, Alice and Martina, for an overview of the WHO recommendations, as well as providing the definition of adolescent-friendly health services and why it is so important in terms of increasing engagement and improving outcomes for adolescents living with HIV to implement adolescent-friendly health services. And now Dr. Valentina Baltag will present on global standards for quality healthcare services for adolescents. Dr. Baltag is responsible for adolescent health policies, planning, and programs in the Department of Maternal, Newborn, Child, and Adolescent Health in WHO Geneva. She is an advocate of adolescents' rights to quality healthcare services and protective social policies. Her work focuses on supporting member states to develop and implement policies that address, from a life course perspective, the main areas of concern such as sexual and reproductive health, mental health, nutrition, violence in an integrated way. She's an author of various publications on school health services, strengthening primary health care, quality of care, and preconception care. Without further ado, I'll turn it over to Dr. Baltag for her presentation.
Thank you very much. Good afternoon, and I will probably start my 10 minutes talk with saying that adolescent-friendly health services is not only about having a special use clinic or a dedicated adolescent facilities. Unfortunately, very often adolescent-friendly health services is understood as such. What we mean by adolescent-friendly health services, and we actually prefer the term quality healthcare services for adolescents, is that every healthcare facility, be it a health center, be it a district health facility or a tertiary hospital, if the facility has adolescent clients or intends to attract adolescent clients, it has to provide quality healthcare services for adolescents. So that's why we decided to spell it out, what it exactly means adolescent-friendly health services. And our previous publications that Alice has shown the cover were explaining that basically adolescent-friendly health services means services that aims to achieve a better access for adolescents, that provide acceptable services, that provide appropriate services, effective and equitable services. Now, when you explain or imagine a facility manager and you tell him that, well, you have to make your facility to provide more acceptable services or more accessible services, it does not necessarily speak to the way of thinking of facility managers. So one will have to spell out what exactly needs to be done in this particular facility or in a network of facilities in order this acceptability, for example, to increase. So we decided to put those service aims into the service standards, which I will explain in a minute. But first, very briefly, why do we need to look at the quality of health services for adolescents differently, discreetly from adults or children? Alice explained very well. The basic mistake that we all make as adults, as policymakers, as providers, as facility managers, is to assume that adolescents are older children or younger adults. If we think so, then the implicit conclusion is that we provide for them services the way we provide for everybody else. And for example, in the HIV community, you can think, okay, if I have an adolescent with the HIV, and now with the new recommendations, there is no different dosage, there is no different onset of the treatment, so the clinical aspects of the care are the same. But that's exactly the point. adolescents are different in many ways from children as clients in healthcare and from adults. And those differences come from for two reasons. One is the biological, the developmental reasons, which is related to this particular age, which is about the physical development, neurocognitive development. And changes occur that are not present in adults or not that present in children, which do happen in adolescents. And the second source why they are different is basically socially constructed, is because we as adults have very strong opinions about what is an appropriate behavior in adolescents and what is the onset of this behavior and so on. So they are unique in many ways, and I will not go into details, just to say that this uniqueness has very concrete implications for the way you organize your consultation, for the way you speak to adolescents, for the way you organize the follow-up. So then to standards. A standard is basically a statement of a defined level of quality in the delivery of services, and it defines the performance expectations. That is what you want to achieve in terms of the structure, in terms of the process of the care, and in terms of the other aspects. So last year we launched the global standards for quality healthcare services for adolescents. I will not speak how they were developed and what is the evidence base behind. You can access the document and see. But just to briefly present what you can find in this document. It is published in 4 volumes, and volume 1 sets the rationale for improving the quality healthcare services for adolescents and present the standards and their criteria. So the criteria is a measurable element of a standard. You will see in the next slide what are the standard statements, but be assured each of those broad statements measurable elements. Then the volume 2 is the implementation guide. And this implementation guide is a roadmap of what are the actions at various levels that need to happen in order you fulfill the standards. Volume 3 has a full set of tools to monitor standards. There is no scope, no reason to have quality standards if you do not measure them, and then if you don't take actions to make improvements based on the results of your evaluations. And the volume 4 helps to, it contains the formula for scoring sheets and data analysis. So now what are the standard statements? We came up with 8 standards. The first one is about adolescent health literacy and what needs to be done in order the facility has systems to ensure that adolescents know about the care available, but also know about the health and how they can enhance their own health. And this standard has 9 criteria, which is basically spelling out what this standard exactly means for a facility manager, for the providers, and for adolescents. Standard number 2 is about community support, and this standard has another 8 criteria, which explains what needs to be done in order the facility has systems so that parents, guardians, and other community members and community organizations support the provision of services to adolescents. Standard number 4 is about the appropriate package of services, and it is very important because very often the so-called adolescent-friendly health services initiatives were focused on only on sexual and reproductive health issues, which is very important. But what this standard says is that adolescents need comprehensive package of services, meaning that other needs, such as mental health needs, for example, needs to be addressed in the same time as, for example, HIV-related issues. Then standard number 4 is about provider competencies. Again, it has very concrete measurable criteria, and then in the implementation guide you will find actions to implement those criteria. And this is, again, very important standard because you cannot achieve any quality without well-trained providers that have not only enough clinical knowledge, but also the right attitudes. Standard number 4 is about the facility characteristics, such as convenient operating hours, welcoming environment, and the environment that is able to maintain privacy and confidentiality. And then it has all the necessary equipment, medicine, and supplies. Then standard number 6 is about that all adolescents, not only a group of them, have the same quality of services irrespective of their ability to pay, age, marital status, and other social characteristics. Standard number 7 is about data and quality improvement, what exactly needs to be done, and how adolescent lenses should be brought into the quality improvement initiatives. And standard number 8 is about adolescent participation. And don't take it lightly. This standard is not merely to emphasize participation as a principle, but to emphasize the very important 2 aspects of participation for the quality of care. One is participation in own care, that is, decide about every aspect and every next step of the care together and with the healthcare provider, and then participation in informing the facility and giving feedback and basically participating in the design and how the services are organized. The guidance provides, as I said, also a guidance on the implementation. In this slide, you see the key steps in the implementation. And I want to emphasize, and the volume 2, the implementation guide, gives you a very detailed list of actions at national level, what needs to be done at national level, at district level, and at the facility level. Because the standards are written from a facility point of view, but obviously there is that much that the providers in the facility and the facility manager can do. So some things needs to be to happen at other levels, such as, for example, a continuous professional education program or training in adolescent health is not designed by facility manager. It should be available, and it is a responsibility of national or subnational authority. So this is to say that in order the standards to be implemented, a lot can be done locally, but not everything. So a national and subnational commitment is necessary. Now, from the actions on this slide, I want to emphasize that WHO can support countries in those key actions, especially in developing a shared understanding on adolescent health and the needs for quality improvement, to conduct a situation analysis, to inform the adaptation of the global standards, and, for example, to monitor and evaluate the implementation of standards. We also developed a policy brief that you could see in the previous slide, so you can read more about this tool and other tools available. We developed those infographics, which is the summary of some key points from this document about what health workers can do, what can governments do, and I encourage you to use it in your advocacy, but you can also use them in the facilities. And just to tell you that they are available on WHO website in all 6 WHO languages, including the poster about what adolescents can do to implement. Now, my last slide is about another tool, I would say complementary, because we say that the key for the implementation of those standards are well-trained providers, and these providers should be trained not merely on the IRV treatment and new dosages and new approaches in terms of treatments and initiation of the treatment, but they should be treated in adolescent-specific aspects of care that go beyond HIV. So what are those core competencies that needs to be in place? Is spelled out in this document, core competencies in adolescent health and development for primary care provider. It sets up 3 domains for competencies. and also it includes a tool how to assess the curriculum of a given institution or a training program, whether or not the content reflect those core competencies. So I will stop here, and I will just say that this convergence between a quality of care approaches which benefit not only HIV. If you improve the quality of care, you will achieve better mental health outcomes, better access to sexual and reproductive health services, better access to information and services on nutrition, and so on. So in the context of the integrated care, it is very important. But if you do so, and the evidence showed and the new recommendation is clear about it, if you do improve the quality of care across all those issues, then it will certainly benefit HIV-related outcomes. I think it's the last slide.
Dr. Valentina, hello?
Yes?
Is that your last slide?
Yes, it is my last slide.
Okay, great. Thank you so much for your presentation and discussing and describing for us the standards of quality health services for adolescents. And right now, we'll open it up for questions on these two presentations before moving into our next round of presentations, which will be very brief. There'll be 5 minutes each, so about 15 minutes in total. But before that, which are really concrete examples of some interventions and of the evidence that fed into the guidelines, we'd like to open it up for questions now on these two presentations. So feel free to type in your questions or to unmute your mic to ask your question of our presenters. Any questions, any thoughts? Okay. Again, feel free to type in your questions as we go, and we'll get back to them at the end. Susie, I see that you're typing. We can't hear you, but if you'd like to type in your question, that would be great. So Susie from UNICEF in DRC, I think has a question, but unfortunately we can't hear her, but hopefully she'll type it in for us. Martina, Alice, Valentina, any questions for the audience? Any comments you'd like to share, or anything in particular you'd like to hear about? Okay, so we have some questions coming in, slowly but surely. From Ruslan in UNICEF, any specific guidelines available from WHO for adolescents from key populations?
Yes, I can answer that. So the key population guidelines that were released in, I think it was all the way back in 2014 already, they had adolescent considerations within them. And that was an outcome of an absolute dearth of evidence. But then there were joint efforts to look at young key populations, so up to 24, by the Interagency Working Group. And there are now a technical series for young key populations and HIV, which has the evidence, including some of the barriers and examples of different services, as well as some kind of considerations for programming and services, etc. So those are all available on the WHO website, and I actually include a link to them in my presentation, so you should be able to copy and paste that.
Great. Thank you, Alice. Anything to add, Martina or
No.
Valentina? No? Okay. So the second question is from Winnie in UNICEF Tanzania. Do we have any guidance on psychosocial models for providing this aspect of care for adolescents?
No, we don't have specific guidance on psychosocial models, but there is more emerging evidence around peer interventions for adolescents living with HIV. And some of those considerations are included under the retention and other service delivery recommendations. So again, as we have more evidence and more implementation science, and you really feel that there is a push from many people around the implementation science agenda. So we hope to have more of that information to make future guidelines on.
Okay, thank you, Alice. And then our next question from Susie of UNICEF DRC is how the other factors that impact health for adolescents are addressed in the upcoming guidelines, such as factors on education and unemployment. Are these addressed by the guidelines that are set to be released?
So from the ART perspective, obviously remembering that this is a consolidated guideline with, I think it's like 50-something new recommendations, and not much space for all those additional considerations. But those things, were taken also into account when we do the evidence to decision making and inform the decisions that are made, but maybe aren't accurately or not sufficiently articulated within the text. But we do have other broader adolescent information around social determinants, but not necessarily. I'm sure Valentini can discuss that more.
Yeah, well, in the global report, Health for the World's Adolescents, we compiled the latest evidence on the impact of social determinants, various social determinants on the health of adolescents. But if talking about those standards, for example, the standard on equity says that the access and the same quality of care should be provided to all adolescents, irrespective of socioeconomic characteristics. And then another standard says that linkages between the healthcare facility and services in the community should be established. And those services in the communities could be social services, services that facilitate, for unemployed young people, so all kinds of services, but there is no guideline about the factors of education, unemployment, and specific recommendations. Maybe because our mandate is mostly for the ministries of health, and the recommendations are for the ministries of health. But this is something to consider.
I know that there is information that UNESCO has released around young people living with HIV and schools. So that information is also available from UNESCO. Yeah. Mm.
Great, thank you so much. And like I think Alice and Martina and Valentina have alluded to, initiatives such as Dreams and All In are also working on these broader issues that are being mentioned. So they might be a resource for more information on these issues as well. So one last question from Milker Simber of Mothers to Mothers in Kenya. Have adolescents in institutions been taken care of by the standards or been considered as the standards of care have been developed?
Well, not explicitly. So the standards from a healthcare facility point of view, and then if there are adolescents in confinement, for example, then it is a different kind of institution. But I don't see why those standards, which is about adolescent literacy, which is about community support, which is about adolescents' participation, would not be relevant broadly for the adolescents in institutions. So I think it's a very good question, and we know how adolescents in institutions, it's an additional risk factors for various health outcomes. So maybe well, it's something to think about how to develop, or maybe how to make those standards more specific for adolescents in institutions.
Okay, thank you so much, Valentina. And thank you to Alice, Martina, and Valentina for giving us a sneak peek at the upcoming guidelines and for going into detail about what do adolescent-friendly health services mean and what do they look like, and in describing the standards of care for health services for adolescents. Without further ado, we'll move on to the next section of our webinar, which focuses on 3 key pieces of evidence that fed into the development of the guidelines. And the first presentation is by Cedric Nininawaze, who's a jurist and a young activist from Burundi. He joined the National Network of Young People Living with HIV in 2004 and is currently the executive director of the network. As a steering committee member of the Global Network of Young People Living with HIV, or Y+, he has represented the Western and Central Africa region. He is also a fellow of a 2015 Y+ fellow, and he's Burundi's focal point for the Link Up project. Without any further ado, I'll turn it over to Cedric, who will talk about the treatment and care needs of adolescents living with HIV. Thank you, Cedric. Cedric, are you with us? Hello? Can you hear me, Cedric? Can others hear me?
Jessica, we can hear you.
Okay.
Maybe we could go on to move on to Daniela and then try and reconnect with Cedric.
Okay, great.
Apologies for that.
Okay, great. Okay, so I'll introduce Dr. Daniela Mark, who is a senior technical advisor of PATA. And she's a neuropsychologist by training with a special interest in the intersection of HIV and mental health. She was previously PATA's executive director, and prior to that, the head of social and behavioral sciences of the Desmond Tutu HIV Center. And she has produced more than 50 peer-reviewed publications and presentations in the area of uptake and delivery of HIV prevention and treatment, with a specific focus on pediatric and adolescent services. She was recognized in 2013 as one of South Africa's top 200 young South Africans, and she's contributed to global policy, including the development of WHO guidelines. Today, she's joining us to talk about HIV treatment and care services for adolescents and the findings of a situational analysis of 218 facilities in over 23 sub-Saharan African countries. So thank you, Dr. Daniela Mark, for joining us, and we turn it over to you for your presentation.
Wonderful. Thanks so much, Jessica. And I'm really very pleased to be here and able to present the results of PATA's situational analysis to inform the WHO guideline update, and really to do this on behalf of the PATA network, some of whom we hope are on the call today. So really just in today's presentation, I'm going to go very, very quickly through the purpose and methods of the situational analysis, but really just in the few minutes we have focused on its results and key messages. And so the purpose of the situational analysis was really to look at the extent to which programs in sub-Saharan Africa are providing appropriate adolescent HIV services at facility level. And the limited information that we do have, which Martina and Alice both spoke to, the dearth of information, really tends to be derived from urban specialized treatment and care centers. Whereas we all know that in sub-Saharan Africa, scale-up of HIV programs is largely through primary healthcare settings. So WHO, in developing the guidelines, really wanted to understand how services are being provided in decentralized settings. So we conducted the situational analysis within the PATA network and managed to get the survey out to almost 300 facilities using snowball method. We had a cross-sectional survey. It was on a web-based platform and it was available in various languages. And responses could also come in those languages. So moving very quickly onto our results, we managed to, in just 4 weeks, we got responses from 218 health facilities from across 3 sub-Saharan regions, with good representation from across those regions. 23 countries, and really a range of rural, urban, peri-urban, range of healthcare providers within those settings as well. So, and if we look at the number of adolescents in care at those facilities, it's over 80,000. So the healthcare providers responding to the survey really serve a large adolescent population. And when we asked those facilities what their greatest challenge was in providing treatment and care to adolescents living with HIV, their response, whether we asked about initiation, sustaining treatment, their response was adherence challenges. So they were really clear about that as a challenge, and I'm sure that Cedric will also speak to that as a challenge from the adolescent perspective. And yet despite this challenge that facilities are facing and adolescents are reporting, we found that facilities did not have sufficient mechanisms or protocols in place to support adherence. And almost half of the facilities did not have a standardized way of measuring adherence, defining non-adherence. Roughly 40% did not have guidelines for supporting or managing adherence or retention in adolescents. So, and then when we look at adherence counseling specifically, we see more of the same picture. We see that counseling is really not of great quality, and it tends to focus on adherence behavior rather than the drivers of adherence. And often we saw reports of scaremongering and a fear-based approach to counseling, rather than what we would hope to see, which would be a supportive and holistic way of providing this counseling. And then we asked facilities, well, what does work? What approaches or models are you seeing that do work? We just had Winfred asking that question, well, what psychosocial models are available and show evidence of working. And unfortunately, we don't have great evidence. And as Alice mentioned, there's emerging evidence, most recently from Zimbabwe. But our facility respondents did say that peer support, in their perspective, was the most effective intervention for both adherence and retention support in adolescents. And by peer support, we mean involving adolescents as peer counselors, support group leaders, outreach workers, health providers within facilities. And yet, despite this belief and recommendation, facilities did not tend to have adequate mechanisms for implementing peer support. And then when we look at gaps, we see that facilities So roughly three-quarters of facilities, or two-thirds of facilities, are attending to adolescents with pediatric and or adult patients, generally pediatric patients. And I know when we say words like separate and dedicated, concerns arise around resources, what resources separate services would take, especially in the context of scale-up and low resource settings. But Martina mentioned earlier that adolescents are a discrete population with specific needs, and Valentina spoke so clearly about that separate services are not about centers of excellence. It's about how we provide the services. And so when we look a little bit more closely at facilities that are providing separate services, at 35%, we see that the most common approach is to provide even just a few hours a day, once a month, where we see adolescents only, and are able to separate them out from their peers. We also saw very limited transition support, transition really only occurring, of course, where pediatric services are provided separately, generally only in tertiary centres, and half of facilities have no really formal guidelines or protocols in place to guide transition, not great counselling, and really just focused on the logistics, the pragmatic aspects of transition. Also, we saw very poor integration of sexual and reproductive health services, and even where these services were provided, they were really not comprehensive and focused primarily on providing contraceptives and family planning rather than counseling, STI treatment and prevention, education, various parts of what we would imagine as a basic package of care were not available. I'm going to skip this, but really just to say we had some evidence of stigma, unfortunately, coming from within health facilities, and really just, I think, coming from lack of understanding or, just cultural perceptions of what is normal for adolescents and what should be occurring for adolescents, rather than the kind of support that we have been speaking about. And then the next two slides, I'm not going to go into them too deeply, but really just to say, again, the same issues that have been coming up throughout the presentation around lack of data, insufficient data disaggregation and outcomes monitoring, where we really aren't able to see the impact of adolescent services or lack thereof, and the importance of gathering this sort of information. So really just wanting to leave you with some key messages. The first of which is that we really want to speak about ways of supporting adolescents' adherence and retention, how we do this, what implementation science is needed for us to evaluate these models, and very importantly, what we can do in the meantime. Peer support as a very promising model and something that we need to look at supporting facilities to do. Separate adolescent services, even if we start very simply, really good quality transition, taking into account the holistic needs of adolescents, integrated comprehensive SRH services in a supportive environment. Adolescents are continuing to support pregnant adolescents within the context of adolescent-oriented care, including PMTCT and ANC. They should not lose the adolescent focus just because they are pregnant. Strengthen data systems, not just for data's sake, but really to improve services. And finally, we noted that West and Central African facilities, those that we did manage to review, may require special support. Finally, just to thank the co-investigators and co-authors of the study and paper, as well as the IATT Child Survival Working Group and Secretariat, and most especially to the PATA Network, the healthcare providers who are really at the front line and doing incredible work every day. And finally, just to direct you to resources available on the PATA website. These are all hyperlinks, so when you receive the presentations from Jessica, you'll be able to link into all of these resources. Thanks so much.
Thank you so much, Daniela, for your presentation. And we will move quickly to our next presentation. Cedric, are you there? Are you able to hear us and to speak? Hello, Cedric?
So, yes, I can hear. Do you hear me?
Okay, great. Yes, we hear you now. So
Okay, that's fine.
great. Give me 1 second as I reload your presentation. And I introduced Cedric before. He's the executive director of the network of young people living with HIV in Burundi, and we're very happy that he can join us to provide us the perspective of adolescents living with HIV and how it relates to providing services for adolescents and taking care of the needs of adolescents with HIV. So without further ado, we'll turn it over to Cedric. Cedric, if you can select take over as presenter so you can change your slides, that would be great.
Yeah. It's okay.
Wonderful.
So, thank you very much, dear Jessica. Good afternoon, good morning to everyone. I'm just going to share with you findings from a research that have been done by the Global Network of Young People Living with HIV, and we call it Taking Them Forever and Taking Them on Time, the treatment and care needs of adolescents living with HIV. So this research has been done by YPlus, the Global Network of Young People Living with HIV, supported by the GNP Plus and WHO. It has been led in August and September 2014, and we did it in 2 ways. We held workshops with adolescents living with HIV, and then we also ran an anonymous online server. So in the workshop we did it in 4 African countries, and we had 84 participants. And for the online survey, we had 386 respondents, but 170 respondents from 30 countries were eligible for inclusion. And the criteria for inclusion were living with HIV, age between 15 and 29, and also have experience taking ARV as an adolescent. So these findings were presented at the WHO guidelines. Now I just have to update you. So the workshop and survey focused on the following 5 domains, which are understanding adolescents' everyday lives on ARVs, challenges and benefits of ARVs, missing or stopping ART, information and support for adults and services. So in terms of understanding adolescent everyday life on ARVs, so we came up with challenges and benefits. So, in terms of challenges in taking ARVs, we identified from the adolescents who participate in the workshops and the online survey that the frequency and timing of taking medication around their daily activity and the restrictions this place on their lives. Also sleep, traveling, going out to have fun, and being at school were all mentioned as everyday activity that makes taking ARVs difficult. So you can understand that you can't avoid sleeping, traveling, or going out even as a human being. Then another inconvenience was taking them on time and taking them while it's away from home. And also, as some of previous presenters said, the side effects, and also the size and the number of the number and state of pills. So, in terms of benefits, the participants say that ARVs enhance their health and well-being. As you can see, a young man from Burundi said that it reassures me to not get sick. Another benefit that they highlighted is being healthy that enables them to partake in everyday life and makes them. So just as key evidence, 81% of respondents acknowledge that ARVs keep them healthy, prevent new infections, and give them strength to carry on with their work and study. So we also from adolescents who participate in the workshops and the survey, there is a kind of mixed feelings. You can understand that through this quote from someone from Zimbabwe, who said that I accept my zero status, but my dreams are shattered. So you can understand that she accepts to his status, but she doesn't really feel very comfortable with that. So in terms of missing and stopping ARVs, so here you can see with this graphic that there are two main reasons, but which came on the top, which are to forget time, and the other one is to forget to take with them the ARVs while they are out of home. So with all these reasons that have been highlighted by participants, you can find behind them, you can understand that there is issues of adherence and issues of discrimination. Also, for instance, if someone says that he can take it in front of maybe he's in public, or if someone said that he fear to lose when he's in a new relationship and he can't take ARVs in front of his boyfriend or girlfriend, it's a kind of to fear about stigma. So when we asked about their feeling after missing ARVs, being guilty and to have fear dominated the responses in both workshop and survey. And then 35% of survey participants indicate that they had stopped taking ARVs intentionally at least once. And just mention that interruption of the interruption of taking ARVs can be length from 1 month to 2 years, and these were undertaken without consultation with health providers. So maybe when the presentation will be shared, we find some codes. So in terms of information and support for adolescents, so here we can see that friends and family members are those who support adolescents and in terms of in terms of discussing the experience of taking ARVs and HIV, having HIV. So in terms of where they can get information, you can see that hospital and support group, so maybe sometime internet and home, and there at school you can see that it's very, very low, but hospital and support group came on the top. So we asked them what could be the strategies to improve information and support for adolescents. So there are some suggestions. So as the previous presentation, you can see the face-to-face support through counseling, treatment buddies session involving parents, guardians, and role models can really help to improve getting information and get support for adults. You can see the quote from this young man from Zimbabwe who said that help us meet as group and share our experience, as opposed to when someone says at home thinking they are alone. So this is maybe one of the common strategy that even in the workshop and online survey participants were really really highlighted that is very important for them. So then there is also to have RVs in small size and beta testing and different color for identification, and also less frequent doses, maybe monthly or one in year. So regarding services, we try to identify what are good experiences and negative services experiences. So in this quote from someone also from Zimbabwe, you can understand how he's very happy she's very happy about services. She said, I am happy because I'm given the time to express everything that will be bothering me and just have a talk in general. But also there are other negative service experience. For instance, the long waiting time and provider attitude. So at my side there is a quote I really hated. When you read it, you can just understand that there is sometimes something which is boring. You can, with this one from Uganda, health services are not friendly and not every young person is empowered like me to stand for himself or herself and get quality services. So I think this means a lot. Then we also identified some barriers which maybe are not new for you. For instance, that missing schools to attend clinic, and others say that there is a kind of just being given RVs and not provided the opportunity to ask questions or discuss problems. And also sometimes the services are not really oriented to adolescents, and the health system, there is sometimes health system barrier. So these were highlighted by the distance to services, drug stockouts, out-of-pocket expenses, and not access to viral road or CD4 testing. This one I can also testify because I sometimes experience this kind of barriers. So they say that also there is a lack of SRH services. You can say this young premier said there is no privacy and we are mixed up with adults. This sometimes you feel that you are not in your place when you meet with your mom or your dad at the same place, saying some issues may be related to SRH or other things. So there is also some suggestion how we can improve services. So provision of services and information from an early age, especially regarding SRH and disclosure, flexible appointment systems around school times, free, closer to home in community to empower access, dedicated adolescent services at specific times or separated area, safe and stigma-free environments, peer interventions, comprehensive services that address their needs beyond HIV. Also, ongoing effective support, which is critical. Also, support and counseling that ensure understanding of their status, improves knowledge, and is empowering and solution-focused. Skills development and support on disclosure and safe sex. Dedicated, consistent, friendly, trained, and competent provider. So this is maybe that means really a lot about how can be the attitude of provider. So in conclusion, the transitional nature of adolescent and their realities need to be taken into consideration. And also adolescents live with the knowledge that Arabs prolong their life, but they also live with stigma, fear, and the daily reality of taking treatment. There is also a lack of adolescent-friendly services and a psychosocial support compound their struggles. Adolescents need a holistic response from health system, to other.
Cedric?
I'm sorry.
Okay.
Okay. Then also, I was saying that there is adolescents need a holistic response from the health system to adhere to treatment and the retain in care, including adolescent-friendly services and strong networks of peer support. And also, there is a need for further research, including operational research on innovative strategy for treatment adherence, integrated services delivery, and psychosocial interventions. So I would like to end the presentation by acknowledgements to people who help so that this can be done. So there is all young people living with HIV who participated in the online survey and the workshops. But also there is the White Pass Committee and the Steering Group for this consultation, such as Janet Pila, Lumumba Musa, Christine Anyango. And the strong support we got from GNP Plus and the WHO, and 3 people who really support us to make sure this is leading to success, such as Ed Ngozi, Kate Watson, and Aris Armstrong. Thank you very much.
Thank you, Cedric. And for the sake of time, we will move on quickly to our next presentation, which will be delivered by Dr. Peter McPherson, who is a communicable disease control specialist doctor of Public Health England and lecturer in public health at the University of Liverpool and the Liverpool School of Tropical Medicine. He completed his medical training at the University of Aberdeen in Scotland and his MPH at Harvard and his PhD at the Liverpool School of Tropical Medicine. His research focuses on the design and evaluation of interventions to improve HIV and TB care and prevention in high prevalence settings. So without any further ado, we'll turn it over to Peter, and the presentation is loading. He will present findings on service delivery interventions to improve adolescent retention in pre-ART care. So over to you, Peter. Thank you so much for joining us from England.
Thank you very much, and thank you for inviting me to present today. It's a real pleasure to present the results of our systematic review into the effectiveness of service delivery interventions to improve adolescent retention in pre-ART care, retention in ART care, and adherence to ART. I'd just like to start by acknowledging the large number of colleagues who assisted with this review, particularly Chigo Montali and David Ross. So, as we've been hearing, an estimated 2.1 million adolescents are infected with HIV, and about a third of infants infected perinatally will survive into adolescence without treatment. And adolescents face particular challenges in accessing effective care and achieving treatment outcomes. This figure shows the adolescent-focused HIV care pathway and emphasizes the many points at which adolescents can be failed by health systems. And these systems are perpetrated by the frequent socioeconomic, health and well-being difficulties faced by adolescents. And the small numbers of studies that have investigated progression through the HIV care pathway have shown that outcomes are substantially worse than for adults and for children. We therefore set out to systematically investigate the effectiveness of interventions to improve adolescents' linkage, retention, and adherence to antiretroviral therapy, with the objective of really identifying interventions that are effective and that could be applied at scale to improve outcomes for adolescents. We undertook a systematic review and we looked for studies that were published between 2001 and 2014. We searched 3 databases and we included randomized control trials as well as non-randomized studies. We included studies that examined service delivery interventions that were specifically targeted towards adolescents, or where 50% of the adolescent participants, 50% of the participants or more were adolescents, or where we had age disaggregated data relevant to adolescents. Because of some limitations, we did have exclusions. We excluded non-English language studies, and we excluded reviews, commentaries, qualitative studies, and modelling and economics studies. You may be wondering what service delivery interventions are, and we define those to be interventions that were provided through the health system or health providers, excluding clinical treatment options, such as specific ART regimes or combinations. So we wanted specifically to look at interventions that were focused on improving these outcomes, but that excluded specific drug combinations. In total, our search identified 3,138 unique studies, of which we reviewed 74 full texts in detail. The large majority of studies were actually excluded on the basis of age, with the majority of participants not being adolescents. In the end, we included 11 studies in the review, and that comprised of 57,491 participants, although it should be noted that that large number was actually driven by one single study that had a large number of participants from a multi-site study. So this slide here just shows the characteristics of the studies that we included. As you can see, out of the 11 studies, only 1 study evaluated interventions to improve adolescence linkage. Only 2 studies evaluated interventions to improve retention on ART, and the remaining 9 studies looked at intervention to improve adolescents' adherence to ART. Despite the fact that the large majority of adolescents and HIV-infected adolescents live in low-income countries, the majority of studies came from high-income countries, with 6 coming from the US, 1 from France, and 1 from the UK. Only 3 studies came from low-income countries, with 1 from South Africa, 1 from Thailand, and 1 a large multi-site study. 3 studies were randomized controlled trials. Participants evaluated within these studies really fell into 2 broad groups. There were adolescents who had treatment or virological failure and towards whom interventions were specifically directed, or there were studies that directed interventions towards all adolescents presenting for care. This slide may be a little bit difficult to see with the size, but what we found was that interventions were really applied at a variety of different points in the scale. We identified in total 8 different types of interventions that really ranged from kind of interventions applied at the policy or systematic level through to the provider or health facility level, through to the community level or the individual level. Interventions applied at the individual level tended to be intensive, applied in multiple sessions over weeks to months, and were personally tailored to be responsive to the needs of individual adolescents. And in contrast, interventions applied at the provider and health level, and that's things such as adolescent or youth-friendly clinics and opening hours and provision of adolescent-specific services, emphasized individual patient needs less, but had greater potential to reach a larger number of adolescents and use fewer resources. So, with our review of this evidence, what did we find? What works? Well, we found very limited evidence for effectiveness overall. In the one study that evaluated interventions to improve linkage, and that was the presence of adolescents or youth-friendly clinics, the availability of these services had no impact on improving adolescents' linkage from HIV diagnosis to treatment. There were 2 studies that evaluated, two studies that evaluated interventions aimed at improving retention. Adolescents in youth-friendly clinics actually decreased rates of retention on ART and multivariate analysis, whereas centralized care and enhanced youth support in a US clinic improved retention. There was a broader range of interventions targeted at adherence, although most studies were of small size and of low methodological quality. We found some suggestion that interventions such as individual or family counselling, peer support groups, group therapy and peer support, and specific interviewing techniques such as motivational interviewing or educational therapy could increase adherence. Inpatient directly observed therapy was examined in 2 small studies with individuals failing antiretroviral therapy and did show some promise, although effects did not seem to be sustained beyond the period of intervention. And finally, one study looked at the effect of financial incentives, that was varying amounts of monies provided on the achievement of HIV viral load results. And again, with small numbers of participants involved, it showed promising results in early data. So in conclusion, we found few studies and really emphasizing the need that there's a real pressing need to conduct further operational research and implementation science to really work out what works. 9 out of the 11 studies that we identified were very small, comprising of less than 100 clients. And in fact, nearly all studies had substantial methodological and reporting issues that do limit our conclusions. We found only 3 randomized controlled trials with 34, 37, and 65 participants respectively, all of which had substantial methodological issues. And only 3 studies had been conducted in high HIV prevalence countries. 5 studies evaluated routine interventions and 6 studies evaluated salvage interventions. So I think overall we can conclude that there are some promising interventions that may be identified that warrant further investigations for effectiveness. And that would include the effect of financial incentives, group and individual therapy, and counselling and peer-to-peer support, and also the provision of youth-friendly services. So this is sort of the research priorities that we've identified. I think the key point that we would like to make is that in high HIV prevalence situations particularly, a one-size-fits-all approach is not likely to be effective. And indeed, we believe that interventions should span across the systems, being cognizant of the effects that can be achieved at the population level through greater coverage and reach, but also need to be responsive to individual needs and requirements of adolescents. So I'd just like to finish by thanking my collaborators again and for your time. Thank you.
Thank you, Dr. McPherson, and thank you, Dr. Mark. Thank you, Dr. McPherson, Dr. Mark, and Cedric for your presentations, which, taken as a whole, gave us a comprehensive view of the factors that affect access and adherence for adolescents living with HIV from a health provider perspective, as well as the perspective of adolescents living with HIV, and discuss some potential strategies that are effective in improving adherence and retention, but ultimately more research is needed on interventions that work for adolescents living with HIV. So any questions, comments, experiences that you'd like to share? Please feel free to type in your questions or to send in your comments. Julie Dennison from a Project SOAR, which is a USAID-funded population council project, held a 2-day meeting in February to set an implementation science research agenda to improve HIV outcomes for adolescents living with HIV in sub-Saharan Africa. There were implementers, researchers, donors, and adolescents living with HIV who attended, and there'll be a report that will be published from the meeting, including the priority research questions identified. So she looks forward to continued discussion on this topic, and we will definitely share that report once it's released. Any questions from our audience? Thank you very much for staying with us during our webinar. Any questions from participants?
Hello, can I?
Yes. Hi. Welcome.
Hi, this is Basha. I'm with UNICEF Regional Office for Western Central Africa in Dakar. And I want to echo a number of elements that came out specifically from Cedric's presentation, as we are currently in 7 countries in Western Central Africa are running the all-in country assessment process. This is the all-in initiative that were launched last year, and that is about ending adolescent HIV/AIDS epidemic by 2030 as part of the fast track agenda. And the issue of transition in treatment, the issue of adherence, and the issue of quality of services and preparation of the health facility staff to listen to adolescents and accompany them are coming very strongly from different countries like Cameroon, Cote d'Ivoire, Burkina Faso, DRC, Gabon, where we are running this all-in process. Unfortunately, as I see, the majority of the studies that are presented here are in Eastern and Southern Africa region, and sometimes only in English-speaking countries, as we heard earlier. So my plea is that we join hand in support, deepen the work on adolescent living with HIV and other aspects on adolescent key populations, as it was mentioned earlier, especially in area like Western Central Africa, where the indicators are not moving very well in the recent years, despite a lot of support and calls. Thanks.
Thank you, Basha. So you're calling for more investment in research and investigation and programmatic strategies for Western Central Africa or non-Anglophone countries. Thank you so much. Any of our presenters would like to respond or have any insights to what might be going on in that region or forthcoming in that region?
Hi, this is
Hi.
Peter McPherson here, and thank you for your comments. I agree. There's clearly a large gap there that is not yet being met by the research community. In our review, we specifically excluded studies that were not published in English, and we acknowledge that is we acknowledge that is a limitation of our review. However, given the small number of studies that we did identify, even published in English, we wonder whether there is much out there. I would absolutely echo your calls for expanded research in a wider variety of situations, and certainly in Western Central Africa as well.
Hey,
Thank you, Peter.
Can I say something?
Yes, sure.
Yeah, just to join my hand to Abdullah and just say that yes, I think we have the same point of view in terms of how we are really engaging with Francophone countries and maybe Western Central Africa in terms of knowing where our indicators, where are we coming from and where are we going. So maybe it's not just to respond to, it wasn't a question, I think it was a recommendation, just saying that there is a need also to focus on this area so that we can really move at the same time from Eastern and Southern Africa, as we also can move at the same time for the whole Africa. Thank you, Abdelaka, for the recommendation of the point.
Any other questions or comments?
Just to say, this is Alice, just to say that the research prioritization that is needed and other people are approaching in terms of implementation science, and this call that we have for more research, it also needs to include a better understanding through programmatic data and things that are already happening in countries. And most of you know the SI guidance now from WHO advocates for age disaggregation, and the importance of us to continue to advocate that at country level, but also the provision of tools to help support countries to be able to implement that recommendation.
Thank you, Alice, for that contribution. And I think that was also highlighted and emphasized in Daniela's presentation, which showed that about 80% of the facilities included in the situational analysis did not have age disaggregated data, which is quite a high number. So definitely there's a need to try to push towards that. Any other questions around adherence? Obviously, challenges of adherence was an issue mentioned across all of the presentations. Are there any participants who have experiences or questions around adherence, which is a huge challenge for adolescents given their daily realities and concerns? Or stigma. Stigma was also another key theme. Okay, well, I think I want to take some time to wrap up and thank all of our presenters, Dr. Penazzato, Alice Armstrong, Dr. Bultag from WHO, who set the scene for us in giving us an overview of WHO recommendations, and to Dr. Mark and Cedric and Dr. McPherson, who illustrated some key pieces of evidence that went into shaping the guidelines that are upcoming. And I'd also like to thank the IATT Child Survival Working Group, which led the organization of this webinar, and to tell all of our participants that we really hope that this is the first in a series of webinars that focus on adolescents living with HIV, and in particular the intersection with PMTCT and maternal and child health. So we hope that we will have a much broader series that will delve in deeper into a lot of the issues that were raised in this initial webinar. And we had about over 70 participants joining us from many different countries. So thank you very much for your patience and understanding. And over to any of our presenters for last comments and thoughts.
Jessica, this is Martina. Thank you very much really for leading this webinar. I wanted to add from the Child Survival Working Group perspective that these webinar really represent the first step towards having a bigger and broader focus on adolescent treatment and care within the Child Survival Working Group. And we're really looking forward to work together with other colleagues and partners that are involved in the All-In initiative to ensure that we are all aligned and that our efforts in countries particularly, but also globally, are really synergistic and rather than duplicative. And we, again, we have a number of activities included in our work plan for 2016. You've already outlined some of the plans for new webinars along within this theme, and we really hope to continue working together with the partners that may be on the call. And so feel free to reach out to us if you have ideas or you'd be interested to be more directly involved with that. Thanks, everyone.
Thank you. Thank you everyone for your time and attention, and we'll distribute the presentations, the webinar recording, and summary of the main discussion points within the next few days, so look out for that. And we look forward for your continued participation and contribution. If you have any ideas or requests for themes, please let us know. Thank you so much and have a great day.